I'm going to talk about current conventional really therapies. And we look at treating Parkinson's disease, and even though we have been treating it for 50 years now, we have made quite a few strides in the treatment, but when we go down to the basics, there are still a lot of things we cannot do today. You know, when we look at improving the symptoms, we can do a very good job about it. What we have evolved over the years is realize that just treating the motor symptoms is not enough. We also need to look at treating the non-motor symptoms, whether it's depression, whether it's psychosis, whether it's dementia, because just treating the motor symptoms, we have not been able to accomplish everything that we wanted. The other challenge that we face with the treatment of Parkinson's is no matter what we do today for the first 5 years, 10 years, even 15 years, to a certain extent, we can keep our patients functional. But eventually, we kind of lose the war. You know, it comes up inevitably that patients are going to progress, the disease is going to progress, and we are not going to be able to win in the end. And this is partly related to there are certain things we really have not accomplished yet. So we still don't have a cure for Parkinson's disease. Forget a cure, we can't even slow the disease down. You know, our next talk is treatment of motor complications like motor fluctuations and dyskinesias, and we can do a reasonable job managing those, but still, we have to turn to surgery at times in managing those. So we still need certain medications where hopefully someday we don't need to go or take our patients to surgery to help with these motor complications that patients develop. Our other challenges are falls and freezing. You know, no matter what we do, there are no medications that we can help with that. I talked a little bit about dementia and psychosis, and in the last 2 to 5 years, we have made small strides towards helping those, but that's still a major challenge, helping with those symptoms that patients develop. What about orthostatic hypotension? I think the talk this morning or the session this morning was on autonomic dysfunction. We still have challenges managing them, and all the Parkinson medicines we use today, we still end up causing those symptoms. So even though I'm going to talk about helping with motor symptoms, treating the drugs we have to improve motor symptoms, all I can say there is a lot of challenges we still face when you look at a patient with advancing disease. What I personally look at my patients, I've realized that we have, in general, been under-treating our patients. We are more concerned today about the complications that can help with the medications, and due to that, we often end up under-treating the patients. And the challenge again with that is, as the disease progresses, the same medications are more likely to cause side effects, whether it's hallucinations, whether it's psychosis, whether it's other issues. So we try at times to hold the medicines back for really no reason. You know, patients are going to develop motor fluctuations, patients are going to develop dyskinesias, and longer we hold them, they have increased disability related to those symptoms itself. So when we look at disease progression, our patients, by the time they present to us around here, they've already had the disease for up to 20 years. So it's interesting when a patient comes in the clinic newly diagnosed, they often ask us, "Doctor, I have mild disease, correct?" Well, really, deep down we know that's not mild. They have lost 70% of their dopaminergic neurons, maybe even more by the time we see them. And even after they first present with the symptoms, it takes about a year before they actually get a diagnosis of Parkinson's disease. And often, depending on the philosophy of the patient and the physician, it might be another year, 2 years before they are initiated on treatment. So you can realize how disabling some of their symptoms get to a point before we actually start initiating treatment in them. And then once the disease, we start treating them, we end up with the motor fluctuations and dyskinesias, and eventually the dementia and psychosis, which becomes a big issue. So when we talk about conventional therapies, I'm going to cover a little bit what's on this end. I'll go over these different medicines, levodopa, dopamine agonist, MAOB inhibitors, CMT inhibitors, anticholinergics, amantadine is what I'm going to cover today. The non-pharmacological treatment is equally important. Earlier this morning, again, you heard about the importance of exercise when it comes to helping the cognitive symptoms. There are studies showing exercise helping with depression, anxiety, but they also help the motor symptoms. But at times I feel like we give exercise too much of a credit. That's just not enough. We cannot keep our patient going just with exercise. They need medications too. But on the other hand, we should not ignore physical therapy, speech therapy, and other forms of therapy for those patients. And then, of course, we have the surgical therapy, and since my talk is pharmacotherapy, I'm going to just touch a little bit on the suspension, what exactly involves. So today, when we look at the conventional drugs that we have, of course, you remember we have levodopa, which is our greatest medication. It goes in there, gets converted to dopamine, and that's where it acts on the postsynaptic receptors. We have dopamine agonists that act directly at the postsynaptic receptors. Levodopa is always combined with carbidopa in the periphery so that you have more levodopa crossing the blood-brain barrier, because at normal doses, carbidopa does not cross the blood-brain barrier, and it reduces the metabolism of levodopa in the periphery. Of course, you could add a COMT inhibitor here and also increase the amount of levodopa that crosses the blood-brain barrier. And adding a COMT inhibitor, we can increase about 25 to 30% of the levodopa that gets into the brain. Then we use MAO-B inhibitors, which reduces the metabolism of dopamine in the brain. And you could have a COMT inhibitor which also acts in the brain, and that's the other part of the drugs that we have today. So technically, you could have a patient who's taking levodopa, carbidopa, dopamine agonist, COMT inhibitor, MAO-B inhibitor, because even though all these drugs in one way or the other act on the dopaminergic system, they still have slightly different mechanisms of action when we look at the treatment. So when you talk about anticholinergics, they were the first pharmacological therapy that was used in Parkinson's disease. They're basically antagonists of muscarinic cholinergic receptors. So we believe there's a balance between the cholinergic and dopaminergic system in the striatum, and because there's loss of dopamine, there's overactivity of the cholinergic system, and that's why we use anticholinergics. Anticholinergics mainly help the tremor part. They don't really help the bradykinesia, they don't really help the rigidity, and we also know that they have a much higher risk of causing side effects in our patients, especially the elderly patients. So personally, in clinical practice, I use anticholinergics more in my younger patients, especially the ones who predominantly have tremor, or in my patients who are having a lot of dystonia. And as you know, again, the younger patients are more likely to have dystonic symptoms, so that's where I usually end up using them. But again, our challenges using anticholinergics are the side effects that these patients develop. Even at times, they don't realize they're having cognitive issues, but if you do psychological or neuropsychological testing before and after, you will realize how many of our patients end up with cognitive issues. Let's talk a little bit about carbidopa-levodopa. It's our most effective treatment we have. It's the gold standard for the treatment. Pretty much every patient with Parkinson's disease at certain stage of their disease will end up on levodopa. And pretty much every patient who goes on levodopa will respond to levodopa. Of course, there are certain caveats to this rule. One, that you have to use high enough doses to see that they respond. And we usually say at least a gram a day before we say someone did not respond. Tremor, if that's the predominant symptom, may not always respond to levodopa therapy up to a gram. So patients have medication-resistant tremor, and I usually say about 50% in general, their tremor continues to happen. And on the other hand, there's also people who have very mild symptoms. You may not see the response occurring. But to me, levodopa is one of those medications, you put them on, you start a patient on levodopa, and they will come back and tell you, oh, I'm doing so much better since I was last time when I saw you. So that's one of the things with levodopa, that the response is there, and that's a dramatic response that is seen. I often say the patient will give you, I'm 50 to 80% better once you initiate these therapy on our patients. The interesting part is that the half-life is only 90 minutes, and initially we may use the drug 3 times a day. A patient may discontinue it for a week, a month, before their symptoms come back. And that's the buffering capacity of the remaining dopaminergic neurons that provides them with continuous improvement in symptoms But as the disease advances, the response could mirror the half-life of levodopa, and some patients may end up taking it every 90 minutes too in certain cases. Like I said, carbidopa is always used along with levodopa to reduce the amount of levodopa we are using. And in general, we talk about a patient needing at least 75 milligrams of carbidopa a day. So if you initiate it with 10-100, you're going to need a lot of pills to get that 75 milligrams of carbidopa. And that's why initiating, you should also initiate with at least 75 or 100 so they can get enough levodopa in the brain. And of course, side effects of all dopaminergic medications are pretty similar. So you have nausea, you have sleepiness, you have vomiting, and that's part of the reason we initiate at low doses and gradually increase the dose. So when we talk about the current formulations that we have the immediate release carbidopa levodopa, which was our original preparation. And to me, if we could get a levodopa preparation, which is providing continuous improvement in symptoms, I think we may not have the motor fluctuations and dyskinesia challenges that we face. So with immediate release carbidopa levodopa, as the disease was progressing, we realized that was not good enough, and we had to keep increasing the dosing frequency. So they looked for different preparations, and then the next round came, which is sustained release carbidopa levodopa. The thing with sustained release carbidopa levodopa is that it has a slow rise and of course a slower reduction in blood levels over time. So yes, it did reduce the off time at the end of the cycle, but at the beginning of the cycle, it was taking a longer time to kick in. So again, it was a reasonable progression in levodopa preparations, but the challenge still remained because it wasn't fast acting enough for that. Then of course, the final thing was the extended release capsule, and it is still 1:4 on carbidopa levodopa. And the reason why the numbers are different, so that you wouldn't confuse it with immediate release, because with the sustained release, that was one of the challenges, that people were getting confused using immediate release and sustained release as just being a different number. So that was the reason the extended release has a different number to it. And the bioavailability of these extended release capsules are different. So if we convert a patient from immediate to sustained release, we talk about increasing the dose by 20 to 30%. And if you go into the extended release capsules, it pretty much ends up increasing it by 80 to 100% to get an improvement in symptoms. So when the oral medications don't help, or they continue to provide issues with motor fluctuations and dyskinesias, we end up using the enteral suspension. And the enteral suspension is basically used with an early morning dose, a continuous dose during the day, and as needed doses to maintain the symptoms throughout the day as far as the control is concerned. One of the most unfortunate things that has happened with levodopa is there have been a lot of negative issues that have happened with levodopa, whether it was that it is neurotoxic. Although there is no data to clinically show the drug is neurotoxic, no animal data to show it is neurotoxic, yes, in Petri dishes, you can definitely show that levodopa can be toxic to dopaminergic neurons. But the thing is, we never reach those levels in the brain cells in a living person. So the toxicity story is not a big issue. The other issue was that, it can cause motor fluctuations and dyskinesias, which yes, it can. But again, delaying it, we are doing is increasing the disability of our patients rather than really delaying the fluctuations. So I'm going to show you 3 scenarios here. This is early levodopa initiation. This is basically patients using a levodopa sparing therapy, so you're using MAOB or dopamine agonist. And this is a delayed strategy that you don't use any medication till the patient is disabled enough to actually initiate therapy. And here is time 0 at the left end and 5 to 6 years here. And this is the cumulative disability over 5 to 6 years. So what happens is if you initiate levodopa early, you have good improvement in symptoms, then the symptoms get worse, you increase the dose again, the symptoms improve, and then again you keep increasing the dose. But if you look at the cumulative disability over 4 to 6 years, it's right here. Now, if you use the levodopa sparing strategy, so let's say you start an MAOB inhibitor or a dopamine agonist, so you have the disability gets worse, you start them on one of the medications, they get better, but again, they're not as good as you would be with levodopa. Eventually, you have to start levodopa on these patients so they get better. And as the disease progresses, you again increase the levodopa. But this is where the cumulative disability at 4 to 6 years is. And this is where you delay the levodopa until they are really disabled to start it. So the challenge is that if you're delaying levodopa, you're mainly increasing the disability. And yes, we have concerns of motor fluctuations and dyskinesias, and the best thing is that polypharmacy is the best way to treat our patients early, rather than either using an agonist or levodopa to the maximum dose and then going on to the next dose that we use. The challenges that I said of motor complications are definitely there with levodopa. That is one of our challenges. So in early disease, no matter where the level goes up and down, the symptoms are under global control. Patient is in a honeymoon. They are doing very well. As the disease advances, the patient starts to notice some end of dose wearing off. They may have more off symptoms when they first wake up in the morning. So they are again having some fluctuations, relatively easy to manage at this stage. As the disease advances, they also start having the dyskinesias, getting to be a more challenging scenario, and eventually the patient is having the motor fluctuations, dyskinesias, which are much more difficult to manage, and that's the challenge we face with using these drugs over time. So this is again just to show you using levodopa. We are using it more as an enteral infusion rather than oral medication that we have here. So I'm going to pass on to this and move on to dopamine agonists. So dopamine agonists, we in general believe, are not as efficacious as levodopa. So that's one of the challenges behind using dopamine agonists. They have a much longer half-life compared to levodopa, so we can use it 3 times a day, and we'll still have good improvement in their symptoms. And we often don't really use it more than 3 times a day in our patients. The other thing is, with levodopa, one of the challenges is that we take the levodopa, it has to go through the gut. Is it absorbed in the upper small intestine? It competes with amino acids both in the small intestine and at the blood-brain barrier. So using dopamine agonists, we don't have the same competition occurring. So the food interference is much less with dopamine agonists as opposed to oral levodopa that is there. We do know early use of dopamine agonists compared to levodopa, we can reduce the dyskinesias and motor fluctuations that we see with levodopa. But the challenges with agonists in general is they have more sedation, more orthostatic hypotension, more hallucinations, more pedal edema, and more impulse disorders than we would see with levodopa and other medications. So when we talk about dopamine agonists, the half-life varies all the way from 3 to 6 hours to 12 hours a day. Bromocriptine is an older dopamine agonist which we really don't use much in clinical practice because it's an ergoid-derived and because of the risk of side effects that you end up having with pulmonary fibrosis, etc. So we have pramipexole, immediate release with 3 times a day, extended release once a day, ropinirole, immediate release, ropinirole, extended release. Then you have a transdermal preparation where it is absorbed transdermally. So patients who have GI issues, you can actually use a transdermal preparation. And then you have apomorphine, which is a subcutaneous injection. And often we look at it as a rescue therapy in our patients if we use it as an injection. So I'm not going to go over this chart. This is just a reference chart showing that dopamine agonists, you have to initiate at a very low dose, and you have to gradually increase the dose to reduce the side effects that the patients occur. Because if you initiate them at high enough doses, you will definitely have side effects. So that's the biggest thing with dopamine agonists is initiate slowly. Now when you look at the different agonists that are there, one oral agonist is not superior to the other. It's more which you are comfortable with, what your patient would tolerate better, and hence it's always useful if you have a patient who cannot tolerate a agonist that you try a different agonist and they may be able to tolerate that better than the other one. So if you look at the efficacy, it's about the same no matter what agonist you use at initial therapy in your patients. Whoops. So dopamine agonists can not only be used as monotherapy, but also in patients who are on levodopa, having off time, you can also use dopamine agonist as additional therapy to reduce the off time. In general, we talk about oral medications reducing off time by 1 to 2 hours. The agonists are closer to 2 hours compared to MAO-B and COMT inhibitors, which are closer to 1 hour or so. So I talked a little bit about apomorphine. Apomorphine is a dopamine agonist. It can be as efficacious as levodopa. You can use it either as an injection, as a rescue therapy, or you can use it as a continuous therapy. As a rescue therapy, you pretty much end up using it in certain scenarios. One of them is patients who get up in the morning, have early morning off, they take a levodopa dose, it may take 45 minutes, an hour, and some of our patients, they may not even kick in until they take their second dose. And using an apomorphine rescue therapy turns them on within 10 to 15 minutes, and they have a response for about 60 to 90 minutes, so that's the rescue that works. The other patient is patients who have dose failures. Again, you could use an apomorphine rescue therapy at that time. Or patients who are having food interference. Whenever they have a meal along with the levodopa, they are off. So this injection as an agonist is more used in advanced therapy rather than early therapy. The next group of drugs are MAO-B inhibitors. MAO-B inhibitors can also be used as early therapy, as monotherapy, or as advanced therapy in patients who are already on levodopa. When you look at early therapy, the most commonly used ones are selegiline and rasagiline. And again, when you look at the clinical data that we have, efficacy-wise, they are pretty similar as it's used in early disease. When you look at advanced disease, we have different preparations of MAO-B inhibitors available. Of course, we have rasagiline, we have selegiline, then we have an orally disintegrating selegiline that basically is absorbed through the mouth. And now we also have a new MAO-B inhibitor called sulfonamide. So we have a number of different MAO-B drugs available. And again, the efficacy-wise, they are pretty similar to one another. And again, you're not going to combine multiple MAO-Bs in the same patient. Look at the COMT inhibitors. We have entacapone, and you have a combination of carbidopa, levodopa, and entacapone called triple combination. You also have tolcapone. Tolcapone, we believe, was the most efficacious COMT inhibitor available. The challenge with tolcapone was that in the United States, there were 3 liver fatalities that occurred. Since then, we have a lot of restrictions in using tolcapone. A patient has to fail all of the therapies. If they don't respond in 3 weeks, the therapy has to be discontinued. If they are continued on it long-term, regular liver function monitoring is required. Hence, tolcapone is not used much in clinical practice, and by default, entacapone is the one that is the most commonly used one. When you talk about the side effect profile of these different drugs, you look at all the drugs that are out there, they all have similar side effects like I mentioned earlier. The issue comes down to is dopamine agonists have the most side effects, and MAO-B has the least side effects from that point. So whenever we use any medication, we have to balance the efficacy versus the side effect profile. So when you look at the efficacy versus the side effect profile, and here I have the symptomatic efficacy at the top and the risks at the bottom, we'll start with symptomatic efficacy. Levodopa is the most efficacious, dopamine agonist next, and MAO-B the least. When you look at the acute dopaminergic side effects that are there, so we're talking about nausea, vomiting, agonists are the worst, levodopa is next, and MAO-B is the least. Then as far as reducing or preventing motor complications, that's OFF and dyskinesias, agonists are better than MAO-Bs. As far as the convenience is concerned, once a day, not requiring any titration, MAO-B is the best. Then you have dopamine agonists, and then levodopa. But if you look at the side effect profile-wise, whether it's somnolence, hallucinations, impulse disorders, or pedal edema, agonists are the worst, and then you have levodopa with MAO-B being the least. So efficacy-wise, levodopa is the best. Side effect-wise, MAO-B are the best. So in either case, agonists end up being most likely to cause side effects with middle efficacy between the 3 group of drugs. Again, these are the side effect profile in advanced disease, and I'm going to skip over this one for you. So I would like to talk a little bit about amantadine. Amantadine, as you know, is an antiviral drug. The exact mechanism of action in Parkinson's disease is not known, but it is believed to have multiple actions, including the uptake of, reducing the uptake of dopamine, also glutamate NMDA antagonist. It does have benefit in early disease as far as improving bradykinesia and rigidity is concerned, but in advanced disease, it really helps with the dyskinesias, and that's the main part of where it is used. Recently, we had approval for amantadine ER, which reduces not only the dyskinesias, but also the off time. So here is to show you with amantadine ER the improvement that occurred as far as reducing the dyskinesia is concerned, as well as reducing the off time. So with amantadine ER, we can get much higher plasma levels with it compared to immediate release amantadine. And with immediate release amantadine, we don't have any data to show that it reduces off time. But with the extended release, we were able to show not only that it reducing dyskinesias, but also reduces off time in our patients. So just to summarize here, we have a disease which is about 20 years. As far as using our different drugs, we have MAO-B inhibitors, which we often start early, and usually by 15 years or so, we try to look at it where it is advanced, whether they need these drugs or not. Dopamine agonists and levodopa we usually initiate around this time, and then as the disease advances, when they get to the resistant symptoms, we may start taking away the dopamine agonist. However, levodopa, we kind of continue it throughout the disease course. CMT inhibitors we usually initiate when they develop motor fluctuations, and again, when they develop resistant symptoms, we kind of hold those back. And then, of course, you have deep brain stimulation and carbidopa, levodopa infusion therapy. I talk about treatment in general of Parkinson's disease as being a diamond-shaped curve. Initially, as the disease advances, we keep increasing the doses of the different medications. Once we end up getting to the resistant symptoms, whether it's the psychosis, whether it's the dementia, whether it's the falling, when a patient ends up in a wheelchair, we often start reducing their medications to keep the non-motor under control. So this was an idea of the conventional therapies that we are using right now. And with that, I'll be happy to take any questions that you may have. Thank you.
Thank you.